Welcome back, everyone. Today is lecture 6, and we're going to talk about neglected tropical diseases. This particular lecture is going to be a little bit more in depth. I must admit, neglected tropical diseases is what my specialty is. At Management Sciences for Health, the organization that I work for on an everyday basis, NTDs is my focus, and I'll get into some of these diseases that we focus on for NTDs, but I just wanted to let you know that this is has a special interest for me, so I'll be going a little bit more into detail on this. I hope you guys enjoy this particular lecture. Let's move on to start with. So, again, just a second. So, what are NTDs? There are 17 major NTDs that exist. They are primarily diseases that are common in developing countries. As we mentioned before, Africa, Asia, and Latin America tend to be the largest conglomerate of them. However, they're not exclusive to those areas, but we will focus primarily on those areas. NTDs are ancient conditions. Many of them have been around for thousands of years. For instance, some of the mummies that have been discovered in ancient Egypt actually have been shown to have schistosomiasis, one of the particular NTDs. Leprosy has been mentioned in the Bible numerous times, so they have been around for a very long time. What distinguishes NTDs from other diseases is that they disproportionately affect the world's poorest population. They primarily affect subsistence farmers and families in extremely rural areas. They tend to be very difficult to get to. Healthcare is not optimal in those areas. But also, you can even see them in urban slums. You would think that in an urban area, they'd be able to get access to medical care. The problem is that when you have such a slum area, that the access can be difficult because it's difficult to find people that are affected. There's no addresses, and so it's very difficult in many ways to actually get access to those people. What makes them different from other diseases and why they don't get a lot of attention, the term why they get the term neglected, is because they don't really kill you. They cause a lot of disability and cause a lot of morbidity, but not much mortality. And as a result, they don't get a lot of the attention that some of the other diseases like HIV, malaria get. One of the major aspects of these is that they actually promote poverty and that they interfere with economic development. Because they cause a lot of disability, they can cause issues like education hindrance of being able to work, and we'll get into some of those as well. But it's one of those issues that poverty begets poverty, and this is one of the disease states that actually exacerbates the whole problem. So what are the individual NTD diseases that exist? They can be segmented into three major groups. You've got the protozoan infections, the bacterial infections, and the helminths. The protozoans we talked about in the last lecture, previous lectures, African trypanosomiasis, Chagas disease, and leishmaniasis. But also there's bacterial infections, Buruli ulcer, leprosy, trachoma, and trypanosomiasis. The helminth infections, which is basically also a type of worm, include the ascariasis, hookworm infection, trichuriasis, schistosomiasis, lymphatic filariasis, onchocerciasis, and dracunculiasis. I'll get into each of these in more detail as well. We're going to focus on some of these, but not all of them, and I'll get into why I'm going to focus on them in just a second. So why tackle these NTDs? NTDs promote poverty. That's very plain and simple. They are a significant impact on maternal, newborn, and child health. So maternal child health programs tend to overlap NTD programs. They result in poor outcomes for women, resulting in anemia and malnutrition from the STH, or soil transmitted helminth infections, as well as clinical disabilities, which also tend to exacerbate the health and development of their families, because the women are affected and the children are affected. They can't produce the necessary education for the children, but also the women can't take care of the family, and has long-term effects on that. I mentioned poor educational outcomes. There's been several studies that have been done to demonstrate that physical and cognitive development are hindered from a lot of these infections, specifically the hookworm infection, and that children cannot attend school, and because of the anemia and because of the malnutrition that results as well, they can't pay attention as well, and so it absorbs the lessons and results in lower attainment of the education experience. Of the 562 million school-aged children in the developing world, worm infections are estimated to cause about 16 million cases of mental retardation and poverty in primary school children, and 200 million years lost of primary schooling. So it is a significant aspect of primary education loss in children, and it tends to that loss in primary education tends to move on to secondary education and will later on result in low productivity, work productivity as an adult. They might not be able to get the higher educated jobs necessary, and as a result they end up working in lower educated jobs, and if they get reinfected as adults, they can actually have lower productivity as a result. Infected adults cannot work. They have to stay at home while they're infected. They have to get treatments, which can be, I wouldn't say costly, but for a family making $1 a day, it represents a significant amount of their income. For example, chronic lymphatic filariasis patients are estimated to lose as much as 11 years of productivity, or $50 per year, which results about 15% of their income from the that they could have had if they didn't have the chronic lymphatic filariasis. Trachoma is another example. It's a blinding disease, which if left uninfected can cause permanent blindness. It's estimated to cause a loss of about $5.3 billion annually in agricultural productivity throughout the world. So it's a significant amount of money. $5.3 billion is the GDP of several of the small countries in Africa. So I mean, just the treating trachoma alone could be a major help to economic stability within the region. Sustained economic development cannot occur without addressing NTDs. So we've mentioned the Millennium Development Goals. Some of the Millennium Development Goals deal with economic issues, and so the NTDs is a major aspect of having to deal with those. There are 7 of the 17 that cause 90% of the global health burden, and these are the 7 that I'm going to be focusing on for the rest of this lecture. The 7 diseases include roundworm or ascariasis, whipworm or trichuriasis, hookworm, schistosomiasis. It's also called snail fever, and in some places in Africa you'll see it as bilharzia. Lymphatic filariasis is also called elephantiasis, and trachoma and onchocerciasis are the 2 blinding diseases. One is the trachoma is the only bacterial disease in this list. The rest are all helminths. The 3 diseases, the roundworm, whipworm, and hookworm, they're all classified as soil-transmitted helminths, and you'll see me saying STH as another way of saying that. So what are these individual diseases? Here's just a couple of visuals of what the diseases are. Whipworm is a very small worm. It's found in the intestines. Roundworm can actually get very big. You can see on the right slide here that it actually gets fairly large, and it can cause intestinal obstruction, as well as reduced nutritional nutrients from the children. And it actually has a result in major problems for the development of the child. The life cycles are fairly simple. If you can see here, basically the human will ingest the eggs, and then it will the larva will hatch and basically grow in the human's intestines, and then basically they'll excrete it through their fecal-oral route, or more fecal route, and then it goes into the soil and then continues the life cycle. Both roundworm and whipworm have the same life cycle. And there are certain drugs available if you can actually attack the adult worms using a drug either called mebendazole or albendazole. And so you can see here that those drugs will actually affect the adult form of the parasite. Hookworm, very similar life cycle. There's 2 different species that cause it, but also this particular one will actually enter through the mouth, can enter through the feet as well if you have small lesions in your feet. A lot of people in these developing countries walk barefoot, and as a result they have small cuts on the feet, and they can actually get it through there, or they can ingest it as well. And then it's passed again through the feces. Mebendazole or albendazole are the 2 drugs that are available. Hookworm has a very, very interesting, a lot more data available on hookworm than some of the other diseases. 7 million pregnant women in sub-Saharan Africa are infected with hookworm. That's up to 1/3 of all pregnant women have hookworm infections, and it can have some serious problems for the fetus as well. Reduced birth weight, increased perinatal child mortality, increased maternal mortality, so the women are higher chance of women dying through pregnancy as a result of hookworm infection. And one of the major aspects of that is the anemia that results from it. That's what causes some of these aspects. But women that are co-infected with malaria, as we discussed before, can cause anemia. So does hookworm. So the result from that is actually the hookworm can exacerbate the anemia that happens from it. The children that grow up that are born with hookworm infections or get infections after they've been born in the early years, from 0 to 5 years old, they can get anemia, reduced growth, psychomotor development, which can actually lead to lower IQs. You can actually see there's a study that the mental retardation as a result of severe hookworm infection can actually be quite significant. But then also a 40% reduction in future wage earnings is potential of that has been shown in some studies. So it can be, even if the child is treated early on, as long as they're treated early on and regularly, where the infections don't become severe, it can reduce the problems. But if they have severe infections throughout the course of their early childhood, it can have long-term effects. So some of the STH prevalence, the WHO is fairly good with releasing these new STH numbers. Every couple of years they release it, I would say, but if you look on the STH website at the WHO, they actually have more regular releasing. It's actually real-time numbers that happen within the treatment programs for each country. But you can see, again, most of the cases are in sub-Saharan Africa. India has a huge number of cases, and some degree in South America and Central America, but not as significant. It's usually more mild cases in there. The next disease I'd like to discuss is schistosomiasis. Schistosomiasis is basically it's another type of helminth infection, and this one actually has the greatest intensity in children and adolescents. Just like the hookworm, one of the major problems with it is anemia, but it can have other problems such as chronic inflammation and also splenic problems, but also some evidence to suggest that the parasite can actually cause, later in life, if it's a long-term infection, can cause bladder cancer. There's two major types of schistosomiasis. There's actually three major types. I'm only going to focus on the two: Schistosomiasis mansoni and Schistosomiasis hematobium. The mansoni version, what will happen is it will actually infect the blood and liver, and the hematobium will affect more. I'm sorry, the mansoni version will affect the liver, and the hematobium will actually affect blood more. And what you can see here is that in this particular strain, there's a human life cycle where the person is infected actually by the worms. What they'll actually do is they'll penetrate the skin if you're in the water. It can be just the feet, it can be children swimming in the water, but you can actually kind of feel it as it goes in. It kind of has this little itchy feeling as it's burrowing into your skin. And it'll grow to an adult form and then release the eggs in the feces again. This particular parasite has a vector strain. It's the snail, so you'll see this typically on the sides of slow-moving rivers or lake beds, and the snails will grow on the reeds, and the parasite will actually enter the snail through that part of the life cycle. Again, there's several different ways you can actually prevent this. They include, there is a drug called praziquantel which is available, which attacks the adult form of the parasite in the human, but you can also use things like pesticides and snailicides to kill snails in the rivers. That actually, just like the DDT with malaria, is effective but has a lot of environmental concerns about it. So you need to do that judiciously if you're going to carry those procedures out. Epidemiology of schistosomiasis, again, almost 90% of all cases are in Africa, and so it's got the highest prevalence there, but there are some cases in the Amazon area of Brazil and Colombia as well. This disease is actually one of the diseases that's targeted for worldwide elimination. Whether that's achievable or not, a lot of people disagree, but it is one of those diseases. The STHs, the target is control. They don't have an elimination plan as of yet. But you can also see here, the child infected here has the distended stomach, which is one of the characteristic hallmarks of schistosomiasis. The next disease I want to talk about is lymphatic filariasis. This is one of the more overt diseases, I would say, that exists for all of the NTDs. You can see the pictures here. There's several species of the parasite, and they actually will infect mosquitoes. So this is one of the few mosquito-borne diseases of the NTDs that we're going to discuss. There are others that we discussed in the vector-borne disease, for instance, dengue, but for the NTD lecture, we're just going to discuss this one. And what lymphatic filariasis can cause is two major sequelae. One of them is elephantiasis, you can see on the bottom left, the person with the large foot, and the other is hydrocele, which is actually fluid filling into the testicles, the scrotum specifically. And what ends up happening is the parasite blocks the lymphatic system, and basically creates a dam within your lymphatic vessels, and blocks the liquid from forming in it, and so you get this blockage and it starts to swell. So the swelling can happen typically in the leg. It's usually unilateral, or it can happen again in the scrotal area. Women can get it as well, but not as common. The treatment for this one is, let me just go over the life cycle real quick. So the life cycle has, as I mentioned before, a mosquito section, very similar to malaria, and a human life cycle. And the different strains have very similar, the different species have very similar life cycles. There are several drugs available for this, and they both attack the adult form of the parasite. And what it is there's a drug called DEC, or you can use ivermectin and albendazole. Remember, albendazole was used for the treatment of STH as well. So if you're treating for lymphatic filariasis, if the person is co-infected with STH, you're also treating for that. And then there's also several control methods that you can use, such as bed nets and pesticide. We'll talk about some of those methods. What's interesting about the lymphatic filariasis is you can actually attack another way, is to attack using tetracyclines. The tetracycline doesn't actually kill the parasite. What it does is it kills a bacteria that's a symbiotic bacteria within the parasite. And that, if you can do that, you can actually weaken the parasite enough. There's a lot of studies going on regarding tetracyclines with using against the bacteria, but it's not used on large scales as of right now. The epidemiology for the lymphatic filariasis is, again, it's mostly, you'll see it in Africa, it's still in pockets in Brazil, and then the major aspect of it, major population that has infected is India. Almost all of India is endemic for it, and almost 600 million people have the disease. The next one we're going to discuss is onchocerciasis. This is one of the two blinding diseases. Onchocerciasis is also called river blindness, and you'll see here that the first image you have on the center top, you have these little nodules that form, and that's the first sign of infection. And these nodules are effectively the parasite growing in the lymphatic, in the pores in the skin as they're trying to travel from the site of infection to the eyes. And they're very painful, those nodules, but as the disease progresses, the person will become more and more blind, as you can see on the right-hand slide. And in the bottom center slide, you can see the child actually guiding the adult. And this is a very, very symbolic picture. This particular picture was turned into a sculpture, which is actually located in 3 locations. You can actually see one at the World Bank in Washington, D.C. There's another one in front of the WHO in Geneva, and then Merck Pharmaceuticals, who developed some of the drugs for these diseases, actually has one at their headquarters. So onchocerciasis is a very, very famous disease from a public health standpoint. It's one of the first diseases, other than smallpox, that was actually targeted for elimination, and the program has been going on for many, many years. It's been quite tricky. This disease actually is one of the earliest diseases for the NTD programs, and we'll talk about some of those programs soon. Onchocerciasis is actually spread by a black fly, as you can see on the slide here, the fly itself, and it'll typically stay on the riverbeds. Usually within 1 kilometer of the riverbed is where it's usually located. And it also has the simple life cycle, again, a human side, and then the black fly side. There's also several drugs available for this. It has a similar profile as the lymphatic filariasis, you can treat with DEC or ivermectin. Mosquito control, I'm sorry, black fly control, forgive me on that mistake there. But black fly control, bed nets to some degree work, and pesticides to some degree work, not as good as the mosquito disease, but it does function. And then the antibacterial disease has some function, but they're not as critical in onchocerciasis. The last disease I want to talk about is trachoma. Trachoma is the only bacterial disease in this list. It is the disease that is the world's leading cause of preventable blindness of an infectious origin. It can easily be spread through personal contact, so unlike this one does not have a vector, but it does have a lot of aspects where, since it's a bacteria, it can be spread through shared towels, through clothes, personal contact, rubbing of the eyes, and then also to some degree the flies, if they have the bacteria on their foot pads, they can actually transmit through the eyes. The treatment protocol for this is usually azithromycin as the primary antibiotic. You can use tetracycline, but tetracycline has more side effects to treat the infection. But then you have three other aspects of it. Surgery to reduce the blinding aspect of it, facial cleanliness and education to make sure you wash your hands and wash your eyes to prevent it, and then environmental improvements in areas where water and sanitation are reduced to reduce the transmission of the disease. If an eye is left untreated, repeated trachoma infections can cause severe scarring of the inside of the eyelid, and I'll show you a picture of that, and can cause the eyelashes to scratch the cornea. In addition to the causing pain, trichiasis permanently damages the cornea and can lead to irreversible blindness. One thing I should mention about the NTDs, which I haven't done yet, and I think is critical, is to say that it's not an issue of whether you're infected or not. It's how much you're infected. So if you are infected with a worm, one worm may not hurt you. But if you've got, get continuously reinfected and reinfected and reinfected, the numbers start to add up. So you might have 1,000 worms, and you might have 10,000 worms, and 100,000 worms. It might only be after 100,000 worms that you'll start to get problems. So just be aware that it's not, is the person infected or not, it's how much they're infected is also critical to understand when you're dealing with the NTDs. Back to trachoma. I'm sorry about that little side note, but back to trachoma. So here's just a slide of what the trachoma looks like. What you actually get is on a normal eyelid, you'll see, it's a nice healthy pink color, but as the trachoma parabacteria starts to infect the eyelid, it starts to get more and more inflamed and red. And as it gets inflamed and red, the eyelid actually flips inward, and the eyelashes will start to scratch the cornea. So the treatment for it, as I mentioned in the SAFE project, the surgery, actually, very simply, I don't like eye surgeries, but what ends up happening is they actually snip the eyelashes off and the skin around it, so that way new eyelashes won't grow back, and prevent basically the eyelid from flipping inward. It won't cure them if they've got any particular damage. That damage will be there, but it'll prevent more damage from happening. Trachoma, unlike a lot of the other diseases, is more associated with semi-arid to arid areas. The other diseases tend to be more in the tropical areas of the more rainforesty areas and more wet areas, but the trachoma tends to be more of the arid areas. So you'll see it a lot more in North Africa. You'll see it in the Middle East, some of the arid areas in India and China, also Australia. Australia being the one fully advanced industrialized country that is infected, but that has it. But you'll primarily in the indigenous populations within the Australian Centraland, which is very difficult to get to. That's one of the main reasons why it's still there. But you'll also see it in the Americas, primarily again in Brazil and Mexico. So it is fairly diverse in where it affects people. So what makes the NTDs more interesting is that of those 7, is that as you saw in the individual slides, that they are in a lot of countries. And what you see is the same countries over and over again, and you'll start to see this overlap. So it's this commonality between the 7 NTDs, and you can actually go further and look at other diseases and add those to this list. But many countries in sub-Saharan Africa have all 7 diseases that infect them. And as a result, the treatments for these could be potentially linked together. And it's these control programs, basically, that allow for the There we go. It's these control programs that, are going to be the main focus for elimination of these 7 different diseases. So the control programs actually started from the World Health Assembly, which is an organization within the World Health Organization. Basically, it's an assembly of countries that set the goals for different diseases, different health issues. And the World Health Assembly has, over the years, have actually called for several resolutions for different NTDs, and then the most recent being in 2013. For each of these diseases, basically, there was a resolution for either control or elimination of the diseases, and in 2013, there was actually a resolution to use the integrated control of the NTDs within programs. What that means is, basically, rather than trying to eliminate LF or onchocerciasis individually, they realized that the overlap of these diseases allowed for them to try to treat them all at the same time and in an integrated fashion. We'll talk about some of those aspects of that as well in the next coming slides. So the rationale for integrated control for these particular diseases, as I mentioned before, the geographical overlap, but they are also concentrated even within the national overlap. You see them within the same underserved communities at the community level. So it may not be that, if you have a country where there's seven different diseases that overlap in that country, at the community level there might be only 3, but it's those same underserved populations that get those same diseases constantly. So as a result, that allows for programmatics to work very symbiotically together. They share many of the same features that make integrated technical guidance both feasible and advantageous. Basically, what that means is the disease might be like a lot of the vector-borne diseases, the mosquitoes and the black flies tend to have the same geographical location, so you can actually start to do integrated vector management, not just treatment of the diseases together and various other things. There's more, because you're actually able to integrate, you can utilize your resources to a higher efficiency. You don't need separate staff for each disease. You can use the same staff, you can use the same distribution pathways, and so on. The common environmental concerns and vectors, again, as I mentioned before, LF and onchocerciasis, but also LF and malaria. If you can utilize a lot of these malaria programs and work with the malaria programs, you can actually tack on huge funding streams from the malaria programs onto a simple LF program. And then cost effectiveness and efficiency of program activities. By joining them all, you can actually reduce the administrative costs as well as technical costs, and so you can increase cost effectiveness. Because you're integrating everything, you get enhanced sustainability. You don't have to train multiple people. One person can be trained for multiple things, and that can actually allow them to be utilized for a longer period of time. And it can also help to combat donor fatigue. If you're not constantly asking for more funds because you've increased the efficiency, you can actually deal with donor fatigue in that way. So what are the major approaches for NTD control? The first one I want to mention is PCT, preventive chemotherapy. This is also called mass drug administration, and it's the primary route in which NTDs are controlled. Very simply, what they assume is that everyone's infected. If you have a community that has 80% population that's infected with STH, for instance, you're just going to treat everyone as if it was almost like a vaccine program. You just assume that they're going to be infected even if they're not. You're not going to test every individual to see if they're infected or not. The profile for the pharmaceuticals themselves have shown to be safe. Even when they're combined together, they've been shown to be safe. So you're not too concerned about adverse drug events, but you still keep monitoring and evaluation for side effects and adverse drug reactions. That's definitely critical. The main ways you can actually do mass drug administrations, again, since most of these NTDs affect children, and they are the highest affected people, a lot of these programs actually work in schools because it's also the central location where you can actually reach a lot of people. However, some of these diseases like the LF and onchocerciasis affect adults just as much as the children, so you actually need to work in communities as well, using community health workers. You might have to go door to door and so on. The other aspect of NTD control is vector control. Mosquitoes for LF, spraying with pesticides, the pesticides against the snails as well, and so on. And then environmental improvements is another key. Most of these diseases are simply have to deal with water and sanitation, poor water and sanitation. So teaching hygiene education can reduce just the burden of this disease quite considerably without any drugs or any other preventive methods that are out there. So just environmental improvements and environmental education are key to the elimination of these diseases. So one of the focuses of NTDs has always been, and one of the selling points of NTDs is that it's extremely cheap. If you compare the treatments for these diseases, the drugs themselves, most of these drugs are now, in fact, all of the drugs that are listed here are actually being donated by the pharmaceuticals directly. And so if you only, since they're basically for the entire planet, so they're effectively free of charge. So all you have to worry about is the logistics costs, the administrative costs, and if you take those into consideration, for all 7 of these diseases, you can treat them for about 50 cents per person per year. You compare that to HIV, which can cost anywhere from $180 to $600 a year. It's pennies. It's effectively and literally pennies compared to it. So a lot of the public health officials that advocate for NTDs aren't saying, you know, we should be funding NTDs more than HIV. What they're saying is do your HIV program, do your TB program, do your malaria program, but if you're treating for all of those, why not just add NTDs to the list? You know, it's a minimal cost, and it has been shown that a lot of these NTDs exacerbate the other 3 diseases, as well as other programs like vaccination programs and so on. So, I mean, it's not just it is a complicating factor in those as well. So by treating the NTDs, you can help treat against the other diseases. So, what's another interesting aspect of the NTDs is that they are tool ready. What that basically means is that the systems are already set up. So, in a lot of ways, you have the pharmaceutical companies donating the drugs, as I mentioned before. You have bilaterals, such as the United States Agency for International Development, USAID, helping to fund it. You have technical organizations like the WHO already available, and they all work with the Ministry of Health to implement the programs. And effectively, like I mentioned before, you can implement the programs through MDAs. You can do a single MDA if you have one disease in the country. You can do multiple. You can do house to house. You can do school-wide. You can use community health distributors, CHDs, to do it, or another term for that is CDTI, community distribution. Specifically, this is for trachoma, but it can be used for other things. So you have all of these tools available. And the way it actually works is all of these organizations have worked together to develop this protocol, basically from mapping to surveillance, from the beginning of the process to the end of the process. And what happens is basically you want to map the disease first. You want to find out where it is, who is infected at the community level. So you'll actually take a survey in different communities, do small sample sizes in various communities spread out randomly throughout the country, and figure out what the percentage of the infection is, who's infected, and so on. Once you've actually established where to actually do the control program, you do mass drug administration for multiple years. It could be 5 years, it could be 10 years, really depends on the disease, and it really depends on the intensity of the disease as well as the life cycle of the disease. Let's just say here you do it for 5 years. After 5 years, you would stop MDA, and you would basically evaluate, have you actually reached your goals? You know, have you actually reached an elimination marker for your particular disease or for multiple diseases? If you have, you would stop MDA and basically monitor, do surveillance for several years, and then you would say, after several years, has it continued to stop? Yes, you don't have to treat. If it has come back, you would need to do further MDA rounds. And you would do this basically until the entire country has been free of the disease. You would always have to do surveillance, as I mentioned with the malaria lecture. You'll always have to do surveillance until the disease is completely eradicated. Because you will, if you don't do it, you might have the chance of resurgence, or it's also called recrudescence, in your community. There's been multiple guidelines for each of these diseases made. There's disease-specific guidelines, there's multiple disease-specific guidelines. You can see here there's disease for LF, or onchocerciasis, and then you also have human helminthiasis that was produced by the WHO, which includes a combination of all of these diseases. But there's also different country guidelines and WHO guidelines. So there's tons of guidelines. The question becomes, which guidelines do you follow? The general rule of thumb is try to follow the WHO guidelines because they are the ones that are leading the elimination goals, and they're the ones that you're going to have to talk to if you want to get elimination certified by the WHO. But you can also work with other issues outside of the 7. Some of them include the vitamin A distribution programs for maternal and child health programs works very closely with deworming programs. So they've actually developed, in cooperation with WHO and UNICEF, a co-implementation guideline for how to actually do deworming and vitamin A distribution for health of infants and children. But also malaria bed nets, insecticidal bed nets, dealing with LF and malaria. So if you distribute bed nets for malaria, there's sections in this particular article guideline that basically discuss how to deal with the LF that might be co-endemic in that particular area. So what are the first steps of it? As I mentioned before, the first steps is mapping, and the way you do this is very simply, you do data collection, sample collection, depending on the disease, it changes the sample. For instance, I mentioned schistosomiasis hematobium. Basically what that causes is it causes a type of anemia which leads to red urine, and you can actually just have a child take a urine sample, and if there's a bloody urine in it and it turns red, they're positive for the disease. Having said that, they may be infected, but at a low dose that the urine doesn't become red. And then also the other version of it, the Mancini, schistosomiasis Mancini, does not cause bloody urine. So you have to do other types of samples. You have to do either blood or urine or fecal samples is a very common type of sample you would take for a lot of the STHs. Surveys, height and weight measurement, and medical history are very common for doing this. And then what you do is after you've done your survey, you take all the data that you have from all the different communities, and you basically measure it for each disease. You can see here 3 different maps of the, let's see, the first one is soil-transmitted helminth, then you have schistosomiasis in the center, and trachoma, and you basically separate it by district for this for the individual districts within the country. This example is Uganda. And then you basically, what you'll do then is you'll overlap all of the different diseases you have, and a district, and you'll look at which diseases have which treatments, and then you basically say, okay, well, which drugs do you need? I need praziquantel for schistosomiasis. I need albendazole for the STHs. I need ivermectin for the onchocerciasis. And you can actually develop from this programmatics as how you're actually going to distribute the drug regimen for all the diseases that affect each individual district. And then from there you would actually start to develop your MDA program. And then the different, as I mentioned, some of the different approaches are the house-to-house administration. You could do booth distribution, special group populations, work, if you have work camps or something like that, it deals with migrant workers, you can deal with those. Community gatherings, and then one of the keys is, as I mentioned before, school-based programs. But in that particular case, you need to cooperate with the Ministry of Education because teachers are usually the one that give the drugs out, not health officials. So the teachers need to be trained for that. It's not very hard. These drugs are very simple. They're usually just one pill given once a year, so it's a fairly easy way to do it. What you do have to explain, though, is to monitor for adverse effects, and that can be a little bit more complicated. But usually, it's done within an hour or 2 hour training for the teachers once a year. So it's not a massive ask of the programs to do that. As I mentioned before, a lot of the drugs are donated. In fact, all of the drugs are donated, and you saw the numbers of people infected. There were, 500 million for this disease, 1 billion for this disease, and you can actually see that the drug donations kind of have to match that if they claim that they want to help the world out, and they do for the most part. For instance, Eisai is donating 2.2 billion tablets of DEC for lymphatic filariasis. GlaxoSmithKline donates 1 billion tablets of albendazole a year for the lymphatic filariasis and soil-transmitted helminth program. As of right now, pretty much every single one of these diseases have the entire world population covered. The only one that's still lagging a little bit behind is the praziquantel donations. It's a little bit more of an expensive drug, and so as a result, the drug donations were a little bit behind on that, but now they're starting to scale up. Merck Serono has upped their donations from 50 million tablets a year to 250 million tablets of praziquantel a year now, and that should help the numbers a bit. Another thing to note is the azithromycin donation is slightly lower than the world needs, and that has a little bit of a caveat to it. The reason for that is because the the disease is a bacterial disease, and they're concerned about resistance forming. So rather than just treating everyone, as I mentioned before, that they treat everyone assuming that they're at risk, with trachoma, rather than treating everyone at potential risk, they treat only the people that have severe risk. So the populations that are treated are much smaller. Zithromycin is also a very expensive antibiotic to use, so they want to monitor that much more closely. And on this slide, you can actually see, even though the drug donations have been going on for many years, in many situations, for instance, the onchocerciasis has been going on for 30 years now. However, sorry, the numbers got chopped off a bit. Let me see if I can't fix that. Hold on. I'm going to pause it for a second, and I will come back. Sorry about that. I don't know what happened there, but I hope I fixed it a bit here. So there we go. So as you can see, schistosomiasis on the bottom left, only up till 2009, only about 8% of the population was treated. Hopefully in the next couple of years, now that as effective as the 2013, those numbers should start to go up because the donations have gone up. But even onchocerciasis, the second one to all the way from the right, they're only reaching about 60% of the population in need, and that program has been around for 30 years. So that's a major disadvantage and a major concern, because what is going on and why is that still so low? And then trachoma, as I mentioned before, is 10%. That's a little misleading because of the issue related to the fact that they're only treating the people at most at need, while this graph shows the coverage that should be for the entire population at risk. So the global proportion of NTDs, like a lot of the other diseases, the NTDs are kind of more or less localized in several countries. The major proportion of them in India, Indonesia, and Nigeria. If you can treat those three countries, basically you basically can treat 50% of all NTDs. When you actually start dealing with individual NTDs, you can start to see the proportions changing a bit. But as a result of that, again, who do you focus on? Do you focus on India specifically and say, well, if we treat India, we can reduce NTDs by 35%? Also be aware that India only has lymphatic filariasis and soil-transmitted helminths. So if you're just focusing on India specifically, you're not going to be treating for the schisto, you're not going to be treating for the trachoma as much, and so on. And then, so how do you actually expand it? So what you can do is again, you have to deal with the ethics of this and the logistics of this. But basically, dealing with those 13 countries or 5 countries or 12 countries can reduce 70% of the incidence. If you could treat these 13 countries, India, Indonesia, Nigeria, Pakistan, China, etc., for STH, you can reduce 70% of the disease burden. For LF, it's even less countries: Indonesia, India, Nigeria, Bangladesh, and DRC, and you could treat, again, 70% of the population at risk. So a lot of people are saying that you scale up in those countries and then start worrying about the others. And then some people are saying you have to focus on all the countries. Just as a matter of fact, DRC and Nigeria are extremely difficult to work in. There's a lot of corruption. There's a lot of political instability, and so as a result, dealing with those countries is extremely troublesome and logistically difficult. So you might not want to necessarily focus on those, but then you're missing a huge chunk of the population. These are issues I want you to focus on when you're actually discussing your particular paper and what you're going to be doing for your intervention. Is how do you deal with the politics? How do you deal with the the geopolitical issues, the instabilities, and so on, and logistics of dealing with the distribution of different drugs, depending on which disease you're talking about. Once you've actually worked out the plan, the plans on what you're going to do, you actually start to implement the programs. And here's just a couple of pictures from some countries in which the programs have been implemented. You can see the school-based program on the left, distributing the albendazole to the children. The measuring stick, I'll explain that in just a second, to the center, and then also community distribution to the right. The measuring stick requires a little bit of an explanation, and this is not just for NTDs, but several other diseases as well. But what they'll do is, a lot of the drugs are based on weight, and so you can't weigh every single child. It would take too much time when you're trying to treat millions and millions of people. So what you do is basically you would say a child of about, say, 3 feet to 4.5 feet is going to average about this weight. And so what you would do then is basically say that weight distribution is a green, and that represents 1 pill. In this instance, the child is a yellow, so he gets 2 pills. Blue is 3 pills, and so on. And so for that reason, they can actually very simplify the drug distribution for the individuals. There's a little bit of controversy on this because what does a child of a certain height in Africa weigh the child of the same height in Indonesia, for instance? Different body types and so on. But it is just something that they use as a generic way to deal with that. Also, an interesting discussion topic if you guys want to bring it up. Reaching these communities beyond the end of the road is extremely difficult. I did not take these pictures, I have to admit. I would have loved to, but these were given to me by Mectizan Donation Program, or the Mectizan Donation Program is also the ivermectin is another name for it. But you can actually see here, I mean, it's very difficult to get to some of these communities. They are in the jungle. You have rainy season, no roads, bad bridges, and so you have to, if you want to do an MDA and reach everyone, it can be extremely challenging. Once you've actually started your MDAs, you have to do monitoring and evaluation. This is critical not just during the process to see how it's going, but at the end to to deal with scaling down of the program as well as certification of elimination. When you're in the initial stages and you're just trying to get basically a ballpark for control, simple tests like a microscopy or looking at the urine can work, or even looking at the eyelids. But as you're getting to the point where you're scaling down and you want to certify that you've actually eliminated the disease, you're going to need much more sensitive diagnostics, such as PCR based or ELISA based, and those can be very expensive. And so having to figure out how are you going to pay for those. A lot of these programs are dealing with, as mentioned before, 50 cents per treatment for all 7 diseases. A simple diagnostic kit can cost you $6 per test. So now you're talking about on a scale of 10 times more expensive just to certify that it's actually gone. A lot of programs don't have that money, so how do you deal with that? These programs actually have been shown to work. They are effective, and you can see here these are some very old studies that were done in the initial stages, and it actually does show that you get these nice reductions in the infectivity of lymphatic filariasis in Zanzibar and South Pacific. Schistosomiasis was essentially eliminated from Egypt. There's some concern now that since the Arab Spring, a lot of the programs have been stalled, and so there's a little concern that schistosomiasis might be popping back. That hasn't been confirmed yet. It hasn't been denied yet, so they're still working on that. And trachoma in Morocco has basically been shown to be reduced. Morocco was actually one of the first countries that have been shown and certified by the WHO to have eliminated schistosomiasis as well. As I mentioned before, scaling down. So scaling down, at what point do you decide when you're going to scale down? In order to prove that you've actually reached the elimination, you have to show through diagnostic tools that you've actually done this. And you have to show that you've actually reached what's called the R0 or R0, where it's equal to or less than 1. Basically what that means is it's the extinction coefficient. It's the time in which one parasite cannot complete its life cycle in the time it takes to get from person to person. So therefore, you actually will not be able to get an infection to travel from one person to the next person. And that's basically the R0 or elimination coefficient. And so that is a very difficult thing to establish what that is. People don't even know yet. So they set goals saying, one, for instance, for LF, it's 1 in 100,000 of people that are at risk. It's an arbitrary number, and when they reach that and they start doing surveillance, they'll be able to fine-tune it to the point where they know for sure what it is. The major problem with the NTDs, and you could say pretty much any disease, is that there isn't a lot of funding for it. Having said that, the funding has increased quite significantly in the last 10 years. WHO, not so much WHO, but USAID, the US government, Bill Gates Foundation, and a lot of other donors are pumping much more money into it. But cost estimates of what they think it'll cost from the entire planet is about $800 million to $1 billion a year to treat every single person of all 7 diseases. When you actually, it sounds like a lot of money, but when you compare $800 million to $1 billion a year to a program like HIV, which is close to $50 billion a year, it's kind of small. But it's even still, there's a $300 million per year gap between now and 2020. And so it is a fairly considerable amount of gap in the amount of funding to be able to get to those goals that they want to have. And then scaling up is another issue. It has to go a lot with the money issue, but it's also about logistics, and personnel capacity, and so on. And in order to reach the required trajectory of reaching 75% of the population, they need to scale up quite considerably, and they're well behind schedule right now. Up till 2015 now, this figure has not been updated, but up to 2015, the trajectory is basically stayed at the current rate, not at the required trajectory. So you have to think that angle of the required trajectory is continuously getting steeper, and it's very unlikely that's going to happen. My personal belief is we'll probably be at the 75% coverage closer to 2035 rather than 2020, but we'll see how that goes. Another aspect of NTDs that's extremely critical to understand is how it's related to other disease states. I talked about how it affects HIV, TB, and malaria, but it also affects other things like education, vaccine programs, antenatal care, child survival, water and sanitation. They all interrelate, and this is one of the key factors that you need to understand for global health in general, not just infectious disease health, but how all these programs interrelate and how they can work together. And that's some of the things I want you to think about constantly when you're talking about global health and public health, for that matter, even in the industrialized world. How can you maximize your efforts by linking programs together, strengthening the health systems? Some of the programs that have actually done this, the APOC, or the African Program for Onchocerciasis, which has been around for a very long time, has done a lot of these integration techniques. For the most part, they tend to be one-offs. They'll do a lymphatic filariasis treatment with an onchocerciasis program, or a vitamin A distribution, or a guinea worm intervention, but they tend to be just one time. They're not integrated within the system directly, and that's something that needs to be corrected. The problem tends to be that funding changes year to year, so as a result, you might have done it one year, but the funding won't allow you to do it the following year. If you can actually incorporate it into the national strategic health plans, it gets a little bit easier to do. Some of the links I wanted to discuss about, we talked about HIV, TB, and malaria, but more specifically, I wanted to mention that, for instance, malaria and hookworm connections. The hookworm I mentioned before exacerbates the anemia, leading to increased morbidity, some mortality in mothers and children, but it also may reduce the immune response and increase the susceptibility to malaria. The same mosquito vectors carry both lymphatic filariasis and malaria, and that's another interesting thing, is that you can coordinate efforts between the two diseases. I'm going to skip TB just for a second and talk about HIV. The HIV links are actually, what's interesting is there's been some disagreement as to whether intestinal worms exacerbate HIV, but they've actually been shown that in a person who has been confirmed to have HIV, it actually can increase the health burden on that person. It increases viral load and decreases CD4 cell counts. But if you look at the chances of developing HIV as a result of being co-infected, that's a little bit more questionable. What is very interesting about HIV and schistosomiasis, I think this is one of the more interesting links, is that young girls where they develop urogenital schistosomiasis, what happens is the worms actually travel to the vagina, and what they can do is they can cause scarring in it and inflammation, and it's been shown that those girls that have urogenital schistosomiasis are 3 times more likely to contract HIV than girls that don't have urogenital schistosomiasis. And there's a huge population of young girls that have it. And so these links are now starting to be more prevalent and demonstrating that you can actually, if you can treat the schistosomiasis, you might be able to reduce the HIV burden within those populations. TB, the links are not as strong. There's some anecdotal evidence that demonstrates that the intestinal worms put people more at risk of developing active TB, and that it can reduce the effectiveness of the vaccine against TB. Those particular studies are, I wouldn't say very strong, but they do start to demonstrate the possibilities of the links between them. Another major issue with NTDs is the funding for research. We talked about the funding for programs, how it's deficit, but if you look at the global funding for the big three diseases, they actually get 73% of all global research funding. When you start looking at the individual diseases for the NTDs, they actually get pretty small. The non-big three diseases get about 23%, 27% total. And if you look at, for instance, the helminth infections, they only get 2% of the total funding, yet they actually can they actually infect close to a sixth of the world's population. So that's quite interesting that tends to happen. And then when you actually look at the expenditures versus the DALYs versus the disability that's associated with them, the total research for intestinal nematodes, for instance, the funding is almost nothing compared to the number of DALYs that it causes. Lymphatic filariasis is fairly high. Yes, malaria and TB get a huge amount of the funding research for it, but if you look at it, it's disproportionate to the number of DALYs that it actually causes. And that's really it for today's lecture. I wanted to thank you. This has been another longer lecture, and I just want to thank you for listening, and we will discuss some more questions if you have any on the discussion board. Thank you very much.